Hello.
Hello, everyone. My name is Megan Glenn. I'm the National Assistant Director of Programs at the American Liver Foundation. I want to thank you all for joining us today for our webinar, and thank you to the generous support of AbbVie for this program. The American Liver Foundation is the nation's largest nonprofit serving people with liver disease. We provide a voice for patients and their families through advocacy, support, research, and education. I would like to thank Dr. Gina Choi and Dr. Sammy Saab and nurse practitioner Jacquelynne Prince, who will be sharing their expertise on today's webinar and providing information about viral hepatitis, specifically hepatitis A, B, C. So let me just start with a few housekeeping items. On the upper right-hand part of your screen, you should see a dialog box. If you don't see that box, you just click the orange arrow and you can use that to expand the window. From here, you can ask questions. So you can ask questions at any time, but in the last 10 to 15 minutes, we'll be answering those questions. We do encourage you to ask anything you want to know. I would now like to introduce Dr. Gina Choi. Dr. Choi specializes in general and transplant hepatology at UCLA Medical Center. She focuses on treating patients with complications of cirrhosis and manages their evaluation and treatment before and after liver transplant. She is well-versed in the newest approaches to viral hepatitis B and C, and she's part of a multidisciplinary team employing the latest treatments for liver cancer. She is also interested in autoimmune hepatitis, PBC, and health caring for women with liver disease, including in pregnancy. Dr. Choi, I will give you the floor.
Thank you so much, Megan, for that very warm introduction. It's a privilege to be here and to interact with you guys today on this afternoon. Okay, so I'm going to start off the show. We're going to do a crash course in viral hepatitis. So I'm going to start with A as an apple as the first one to go. Next slide, please. Hey, Megan, were you able to advance the slide? Okay, so just really quickly, I know we only have 15 minutes for hepatitis A, but this is a quick overview. We're going to talk about transmission, how patients with hepatitis A present, complications of Hep A, treatment, vaccine, which is very important for hepatitis A, because we have a vaccine for A and B. And I think what's really interesting is there have been a lot of recent outbreaks of hepatitis A in the past 4 years, and we're going to spend a little bit of time talking about that as well. Next slide. So in terms of transmission, so the transmission of hepatitis A is usually from person to person. And this vaccine is actually very famous because you always think about it in conjunction with children at daycare centers, because kids can actually serve as a reservoir of infection, and you can actually have it in children's diapers, because this is predominantly fecal oral and spread. So kids can carry in their diapers, so it's very predominant in daycare centers. As you can imagine, because it's fecal oral, it's also very transmissible between people within the same household. And like B and C, you can also get it through sexual transmission, blood transfusions. But in terms of adults, really it's the food that's the most contaminable, I guess you can say, because you have people who have hepatitis E, they interact with B, they interact with food, and then that's how you get it. Next slide, please. So in terms of clinical presentation, so it's almost like having a virus. So you get fever, malaise, fatigue, nausea, vomiting, diarrhea, anorexia, abdominal pain. And after this, you start to notice that you turn yellow. So you get jaundice and itchy, pruritic. These symptoms usually last less than 8 weeks, and they're usually self-limited in the sense that people have these symptoms and it just kind of goes away on its own. Now, it's important to understand that once you get infected with hepatitis A, the incubation period is about 15 days. So when you have it, the stool is infectious 2 to 3 weeks before and 1 week after the onset of symptoms. Next slide. So this is the hardest slide I have in my presentation, but this kind of tells you the clinical, virologic, and serologic events that occur during the course of a hepatitis A infection. So we have here on the x-axis months after exposure, and then on the left you have the titer. So what's going to happen is you start to develop symptoms, and that includes the incubation period that we talked about. You slowly develop symptoms, the malaise, the fatigue, the nausea. And at that time, if a doctor were to check your blood work, you would also notice an increase in your liver test, or the ALT. At that point, you have symptoms, your liver tests are high, and then about 8 weeks or so on average afterwards, your liver tests improve, your symptoms improve, and then you'll notice that that anti-IgM antibody, which tells you when you're acutely infected, initially goes up and then comes down. So that's the blood test that your doctor will check if you're worried about hepatitis A. And then over time, that hepatitis total antibody, which is the IgG, will increase over time. And that's going to give you protection for any further complications or potential re-exposures in the future. Next slide. So in terms of complications, like I said, most people have the symptoms and their body, their immune system clears it and they get rid of it. But a small percent of people actually have what we call long-term complications from hepatitis A. So you can get a relapsing hepatitis, that's about 10% of people, where it's not as bad, the symptoms aren't as bad as the initial presentation, but cyclically, every once in a while, your liver test will go up, and the virus, if they were to check the virus in your blood, that would also go up. 5% have something that we call cholestatic hepatitis, where your bilirubin goes up and you stay yellow for a prolonged period of time. And finally, the most dreaded complication is hepatitis A can cause acute liver failure, meaning all of a sudden your liver gets really sick and it stops working. And that would be an indication for liver transplant. This is less than 1% of cases. However, we do see this with people with hepatitis A, and that's usually patients who have another underlying liver disease like hepatitis B or C, which is what Sammy and Jackie will talk about later in this hour, and also what we call elderly. So the elderly in these studies is considered anyone 50 or over, which is bad news for me. Next slide. So in terms of treatment, so let's say you get hepatitis A. So most people are at home, they're really sick, they don't really see a doctor. But 20 to 40% of people who get hepatitis A actually have to go to the hospital, and they get their what we call supportive care. That's usually IV fluids, because remember they're having nausea, vomiting, nutrition. So if they can't eat, we try to give them medications to kind of address those symptoms and help them get their food intake up. But most people recover completely by 6 months. Next slide. So in terms of hepatitis A, I think it's very important because both A and B have a vaccine. So this is a completely preventable disease. The vaccine was actually implemented in 1996. And it's essentially, there's two flavors out there. There's two types of vaccines, and we'll go into more detail later about what those two vaccines are. They're whole inactive viruses. So, you know, in our transplant patients, we always say you shouldn't get an active, a live vaccine, but this is an inactive virus. There's also a third vaccine that combines both hepatitis A and B. There are actually 2 intramuscular injections, so you're going to get one on the first day, and then 6 months later, you're going to get a booster. Next slide, please. So this is the names of the 2 vaccines. So the first vaccine is called Habrix, and that's from GSK. The next one is called Vacta, which is from Merck. And this is just kind of a breakdown of how we studied these vaccines to see if they work or not. And the real take-home message from this is that for people who get the vaccine, it works. So we're talking about a 94 to 100% efficacy. And they work so well that guidelines do not recommend that we check to make sure it works. We assume that if you got the vaccine, you are now immune. Next slide, please. So in terms of who should get the vaccine, so this is from the ACIP, which is the Advisory Committee of Immunization Practices, and they essentially tell you that these are the people who should be considered or should get the vaccine. So all children at 1 year of age, if you travel to an endemic country usually is Africa, Asia, the Middle East, certain parts of Eastern Europe, South America, the Middle East, If you have chronic liver disease, so if you have any type of chronic liver disease, it'd be terrible if you were to get hit with another liver disease. So we think it's very important for our patients with cirrhosis or hepatitis B or C to get this vaccine. Men who have sex with men is also considered a high-risk group, and so they should also get the vaccine. And homeless people should also get the vaccine. So I'm going to talk about this a little bit more when I talk about the recent outbreaks that occurred. But we know that it's very permissible amongst the homeless population. But other groups that should be consistent, that should be considered for this are basically people where if they get exposed, they can actually transmit to other people, right? So we talk about healthcare workers, food service workers, people who work at daycares, people who work in the sewer system. These are all people who are at increased risk. Next slide. So I pulled this slide straight from the CDC website, and this kind of tells you the hepatitis A cases in the United States starting from 2001. So remember I said that the vaccine schedule was implemented in 1996. And so you see a really significant decrease in the number of patients who have hepatitis A in the United States. However, you'll notice if you look at between 2012 and 2013, you'll see these little blips where we have an increased number of cases. And those fluctuations usually occur in the setting of outbreaks. Next slide. So let's talk about the outbreaks. This is really interesting. So whenever there's an outbreak of hepatitis A, it's reportable to the CDC. So the CDC actually keeps track of all these outbreaks. So some ones that are in the most recent memory that are important to remember is in November of 2019, there was a hepatitis A outbreak due to fresh blackberries. There are about 20 people impacted at that time. The next really important one in terms of even healthcare policy happened between November of 2016 and June of 2018, where there was a huge hepatitis A outbreak among the homeless population, both in San Diego and in Michigan. In San Diego, there were about 850 homeless people that were impacted. There were 590 homeless people that were impacted, and 405 of them required hospitalization, and 20 actually passed away from acute hepatitis A. And this really made us as a society think about how we maintain these outbreaks. So there was a lot of efforts made to increase sanitation. They actually installed hand washing stations because alcohol-based sanitizers don't work against hepatitis A. And they began this huge immunization effort amongst the homeless population in San Diego as well. I mentioned Michigan too, because this actually also happened in Michigan, and that's where they had approximately 850 people affected. I also mentioned in August of 2016, there was a frozen strawberry hepatitis A outbreak. That's where about approximately 143 patients were impacted, mostly in Michigan and Maine. In 2016, there was an outbreak associated with raw scallops from the sushi restaurant in Hawaii, where 292 people got hepatitis A and 74 people were hospitalized. And finally, in 2013, there was a Hep A outbreak associated to pomegranate seeds that came from Turkey. Next. So in summary, we kind of reviewed how hepatitis A is transmitted. So we know it's person to person and it's fecal oral, so through poop. The symptoms are usually GI symptoms, liver symptoms, jaundice, but all self-limited on the most part. However, a small amount, about 10%, get more severe complications like the cholestatic that we discussed. One of the dreaded complications is liver failure. So I think for something that's completely preventable with the vaccine, it's important to keep that in mind. Treatment is supportive. There's no medications like we have for Hep B and Hep C. We have two very efficacious vaccines. And in terms of public health concerns, outbreaks are always an issue. And so if you'll go to the CDC website, you can get a lot of information about whether your particular community has been impacted. Next slide. And there are some resources that I kind of pulled my information from. Thank you so much.
Great. Thank you, Gina.
Thank you very much, Dr. Choi. I would now like to introduce Dr. Sammy Saab. Dr. Saab is a professor of the Department of Internal Medicine and Surgery at the David Geffen School of Medicine. He is also head of outcomes research and hepatology at the Flagler Liver Institute. Dr. Saab is active in many local, national, and international committees, including serving as co-chair of the National Medical Advisory Committee for the American Liver Foundation and serving on the national board. Dr. Saab, I will give you control.
Great, thank you. And thank you to Choi and Jackie Prince for joining us today and talking about hepatitis, the ABCs. I'm Sammy Saab. I'm a liver doctor here working with Dr. Gina Choi just down the hall. Great pleasure and privilege. In the next 15 minutes, we want to cover two important objectives. We want to review why hepatitis B is so important to discuss. And secondly, talk about how we manage people who may be infected with hepatitis B. So on the next slide is kind of a picture what the virus looks like. Oh, sorry. Picture what the virus looks like. It's a very tiny virus. We recognize there's 8 different types of hepatitis B. And this is a hepatitis B DNA virus. The virus, as you see in the next slide, replicates in the nucleus, kind of the brains of the liver cell. As a result, it's a very difficult target for antiviral therapy. In contrast, you hear from Jack Prince that hepatitis C replicates in the cytoplasm. And as a result, it's an easier target for antiviral therapy. So hepatitis C and B differ pretty significantly. Hepatitis C can cure with a limited duration of therapy. Hepatitis B, the goal of treatment is to control the virus replicating. Because the virus integrates in the cell nucleus, you really cannot eradicate it. Now, on the next slide, you can see that hepatitis B is a worldwide health concern. It's crazy to believe that 1/3 of the world population has been exposed to this virus. And of this 1/3 of the population of 2 billion people, roughly 354 million are still infected. The significance is that a large proportion of individuals are going to develop complications of liver disease like liver cirrhosis, liver failure, or liver cancer. Now, the tide is turning because of a very effective antiviral therapy. We think that these numbers are much better now than were just 5 or 10 years ago. The next slide we see here, acute hepatitis B in the United States. This is from a study looking at a different number of states and the comparison with Tennessee. And you see here that a substantial number of individuals are unfortunately affected the healthcare system, contaminated needles, etc. They may be infected through drug use. Dr. Choi mentioned men has been at risk for hepatitis A, also hepatitis B. Hepatitis B is a blood-borne virus. It's found in the blood. It's also bodily fluids as well. But drug use has emerged as an important risk factor for hepatitis B transmission. Now, if you look at what we've done as a medical society to kind of stem this tide of hepatitis B, the most effective thing we've done is hepatitis B immunization. And for the past 2 decades, hepatitis B vaccines were recommended to all infants, and there's been a catch-up to vaccinated children as well. So this is resulting in a dramatic decrease of hepatitis B in the United States. It's very uncommon for Dr. Choi and I to see a patient in college hepatitis B. 20 years ago, we used to see a college students all the time with hepatitis B infection. And this has also been shown to be effective in other parts of the world, China, Taiwan, Korea, where hepatitis B rates have plummeted significantly as a result of vaccine. If you think about what we do as a medical society, the most effective we do that's cost effective and impactful is immunization. So right now, adults are also recommended to get vaccines, particularly if they may be users of injectable drug use, have household contacts of hepatitis B. If there are healthcare workers, I'm sure we've all been screened for hepatitis B before starting our jobs and vaccinated. People with chronic conditions, diabetes, hepatitis C, HIV, people who are incarcerated are also at risk and they should be vaccinated. The vaccine comes in different flavors. there's a vaccine accepted recently and available as a 2-shot vaccine that's a couple months apart. And the standard vaccine is 3 vaccines, a total of 6 months of duration. People ask how long these vaccines work. We believe they work forever, forever. This is kind of a picture of what happens with different blood tests after someone's infected. And you see here that, that when someone's getting infected, the surface antigen, it goes up. And that when the surface antigen is positive, that what defines hepatitis B infection. So here's a scenario where the hepatitis B goes away. In other words, a patient recovers, the surface antigen becomes 0 or undetectable. And we are left with our antibodies, particular surface antibody. And this defines immunity. So Dr. Choi and I, or Jacquelynne Prince, check someone's blood test and the surface antigen is negative. It means that they don't have hepatitis B. So as Dr. Choi mentioned, when people have acute viral hepatitis, whether hepatitis A or B, they may turn yellow. They may have flu-like symptoms like fatigue, upset stomach, nausea, discomfort over the liver. And then over time, these symptoms go away. What's fascinating is that in people who develop the illnesses from hepatitis B are the ones where the virus usually goes away. People who are asymptomatic are the ones that go on to chronic conditions. On the next slide, you'll see a typical case where someone gets infected and the infection continues in the patient. It does not resolve. And the way you can tell the difference is by looking at the surface antigen. And you see here surface antigen in the blue that it remains positive past 6 months. Oops, sorry, past 6 months. So surface antigen is positive past 6 months of infection. The patient can start to have chronic hepatitis B infection, chronic. If you get chronic hepatitis B infection, it's very hard to get rid of the virus on its own, very difficult. The next slide is very interesting. And what it tells us is that when you get infected at a youngster, at birth, 1 to 6 months of age, even less than 1 year of age, if you get infected at a very young age, you rarely have symptoms. But you have a very high chance of having the gift that gives on giving, of the virus staying for the rest of your life. But as you get older, and you get hepatitis B as an older child or an adult, you're more likely to have symptoms, yellow eyes, flu-like symptoms, but the chance of going to chronic infection is a lot lower. So when we see a patient, and they're young adults or middle-aged adults or later adults, and they have hepatitis B, and they have a lot of symptoms, we worry about whether it's reactivation or a new infection. If the liver tests are just mildly elevated, and we think they've had it for an extended period of time. And the next slide. Next slide, we're going to talk about a very important topic, and that is the viral load. So the viral load is very important to hepatitis B, probably more so than hepatitis C. And hepatitis C, we're going to hear very shortly, the hepatitis C just confirms infection and is a barometer for treatment efficacy. For hepatitis B, it's a different story. For hepatitis B, the higher the viral load is, the higher liver enzymes will be, the more liver damage, and the higher risk of liver cancer. So when we see people in the office, we're very astutely checking the hepatitis B level because it's got very important prognostic meaning. In the next slide, we're going to say natural history. It's a very complicated slide. Oops, very complicated slide. But basically what it reminds us is that hepatitis B after acute infection can lead to chronic problems. Patients have chronic hepatitis B might get cirrhosis, might even get liver cancer, or even liver failure. Eventually, many people require liver transplantation. But it doesn't have to be this way. We have very effective therapy that actually not only could prevent or reduce the risk of liver cancer, cirrhosis, liver failure, but we have good data to show that it can actually reverse these problems, reverse cirrhosis, reverse liver failure. Very important to remember that people with hepatitis B could also have flares. So someone can be walking on the street feeling fine, and all of a sudden the liver starts failing. And classic examples are individuals who may have received chemotherapy or some immune therapy for an autoimmune condition, and the hepatitis B may flare in this context. The next slide we're going to look at is we'll look at what drives hepatitis B. See, not everybody with hepatitis B has the same complications. Oops, go backwards. Some people may have hepatitis B for many years and really be asymptomatic. We see people all the time who are 70, 80 years of age and doing one with hepatitis B. Other people are 40 years old and have liver cancer. So the risk factors for hepatitis B from getting worse can be stratified into host factors, you know, the age of the person, gender, what the immune status is, ethnicity. It can be stratified to social factors, alcohols like gas to a fire, continuous smoking tobacco, other medical problems like obesity or hepatitis C or Delta, HIV can make things worse. And then there's viral factors, and this is a little controversial, but viral factors as well can predict or are associated with disease progression. The next slide is a very sobering slide on looking at the natural history. And you see on the left-hand screen a very smooth liver. And you see here that it's pretty equal in terms of texture, thickness. And then over time, what we're trying to avoid is bump of cirrhosis. You see here in the middle area, after 20 years, someone's liver could become very hard and bumpy. So the Choi ultrasound, we look for some keywords like nodularity. If we see the word nodularity, that means the liver is bumpy and it's probably cirrhosis. If it's smooth like this, it means the liver is probably normal. And thirdly, when we see patients, we always worry about the risk of liver cancer. We want to make sure we catch a cancer early before it gets to be very big. In this microscopic slide that I know is hard to see as a result of liver biopsy of someone who had liver cancer. And basically you see a lot of cell derangement. So the key thing when we see people in the office is who should be checking for liver cancer. For hepatitis B, there's a number of factors that define whether someone's a high risk or not. First, someone had a family history, first degree relative, sibling, mom, dad, that puts someone at a very high risk. If someone has hepatitis delta or has a high viral load, also puts people at risk. We have cirrhosis as well. We do ultrasounds on our generally every 6 months to look for cancer, and we may supplement it with the blood. It's called AFP. The next slide shows the goals of therapy. So our goal of therapy, when we see someone in the office, is can we have that person live a normal life as possible? So we want to make sure that we can halt the progression of fibrosis, decrease the risk of liver cancer, decrease the risk of cirrhosis, and we do so by lowering the viral level. By suppressing the virus with antiviral therapy, we believe we achieve this goal. The next slide is a very nice slide showing the reversal of liver damage. There's ample studies showing the exact same thing. Now, on this side here is a little complicated, but you see here these nodules surrounded by blue. The blue stuff is scar tissue. And so we talk about treating hepatitis B, talk about reducing the viral level. By reducing viral level, you can actually get reversal of scar tissue. And here you see on the top slide all the scar tissue here, these nodules. And over time, over 1 year, you see that all the scar tissue goes away. And it doesn't matter what medication you use, I think they're all pretty equivalent in terms of suppressing the virus and reversing liver damage as well. The next slide reminds us how we should be thinking about this and how we should be following patients. Oh, sorry. So basically, we want to monitor patients for complications. We want to measure viral level on a regular basis, look at the AOT. In select cases, we may even do a biopsy, or what we're doing more now than before is doing what's called a fiber scan or MR elastography, look for liver damage, and also screen for liver cancer on a regular basis. The issue about monitoring for liver injury is very critical. We consider antiviral therapy when people meet one of two criteria. They have to have a high viral load and a high AOT. Now you can think of situations where someone may have a higher viral load and a normal AOT. In those cases, we'll consider something else like a biopsy or elastography looking for fibrosis. So if someone has hepatitis B, has to be monitored on a regular basis, monitor the viral level on a regular basis, checking for a liver injury on a regular basis, and screening for liver cancer on a regular basis. So hepatitis B is a major public health concern. Every country is affected, may not be to the same extent, but hepatitis B found in all countries. And people who are infected with this virus require close follow-up with imaging, clinic visits, as well as laboratory testing. And with this, I'll stop and pass the baton to Jackie Prince.
Thank you, Dr. Saab. And I would now like to introduce Jackie Prince. Jackie Prince is a nurse practitioner specialist in Knoxville, Tennessee. She graduated with honors from the Medical College of Virginia Commonwealth, and she has 42 years of diverse experience, especially as a nurse practitioner, and Jackie affiliates with the University of Tennessee Medical Center and many other doctors and specialists in the Knoxville area as well. Jackie, I'm going to give you control.
Okay, I want to make sure, can you hear me? Because I'm using my phone. Okay.
Yes.
Awesome. Well, I thank you for the opportunity, and I am here to focus on Hep C. And so first slide should be a global prevalence. Does everybody see that? No? Okay, there we go. All right. So next slide, please. So as Dr. Saab identified, hepatitis C is a RNA virus, whereas hepatitis B is a DNA virus. And the big difference is the site of their replication. The cytoplasm is where the hepatitis C virus replicates, and for that reason, we are where we are today with regard to therapy that can actually directly target that site and basically stop replication and cure the disease. Hepatitis C is transmitted basically by blood. So as opposed to Hep B, which is blood and other body secretions and sex, hepatitis C is predominantly a blood-borne transmission. It also has several genotypes. The genotypes were important 3, 4, 10 years ago, but with the advent of our current therapy, all of our therapies are effective for all genotypes. The one thing about Hep C is we do not have any vaccination for it. So there is not the opportunity, as in Hep B, for getting a vaccination. And certainly they're working on it, but we do not have anything now nor in the very short future. If you look at the global distribution, we've made progress. This chart basically was from 2017. And when you think of where we've come from with the advent of the new medications, these numbers have certainly gone down. Basically, in North America, South America, there was 7 million estimated. But now in North America, we're down to about 3 million. We are making progress, but a initiative through the WHO is that by 2030, we will hope with aggressive surveillance and treatment to have total eradication. So you stop thinking about that is 10 years from now, and certainly very ambitious, but the burden of that falls on those of us in healthcare to identify, screen, and treat. Other kind of prevalence issues is that when this virus was first identified, it was targeted at the baby boomers. So those individuals born between 1945 and 1965 had the highest prevalence of this disease. That has changed in that the new cases that we're seeing now are not in the baby boomers. The new cases are in the late teens, 20s, and early 30s. And the reason for that is our opioid epidemic and the higher incidence of IV drug use. So we're seeing a shift in the patient population that we typically associated with Hep C to now having a much younger population. And I know for myself, I'm in East Tennessee, which is on the border of Appalachia. And I would say a good, easily, like I think of my clinic today, 3/4 of my patients fell in that 20 to 35-year-old range. They are not baby boomers. And so the issue of us being aware that that is a very much at-risk population. Okay, next slide, please. Oh, keep going. So a lot like Hep B, back one, it should say progression. Perfect, thank you. So with regard to the progression of Hep C, very similar to Hep B, is that it is basically initially an asymptomatic disease. When an individual is exposed to Hep C, there is a possibility of 15 to 25% of patients actually fighting the virus off on their own. So people can have been exposed to the virus, but not have active what we call viremia. If chronic Hep C does occur, that by definition is from exposure to 6 months post-exposure, the prevalence of active replicating virus. So people can go forward for 10, 20, 30 years and have no symptoms at all. And that is, it's disturbing because frequently, especially in that baby boomer population, by the time they're hitting their 60s, they potentially were exposed in their 20s and they're showing up and they already have advanced liver disease, i.e. cirrhosis. So in that baby boomer population, we do have a high prevalence of patients now that are coming into our clinics that are actually cirrhotic that may have not realized that they had any underlying disease. And because they didn't realize that, have not adapted their lifestyle with regard to alcohol use and other issues. So this is very similar to Dr. Saab's slide. As you look at the progression of liver disease, initially the liver is, it's smooth, it's sleek, it is not lumpy, and as fibrosis occurs, the liver becomes stiffer and stiffer, and with that there's altered function. So the fibrosis, we know now that even patients that have the beginning of fibrosis, we need to take that seriously because after you treat the Hep C, there is the potential for that fibrosis to basically improve. And so there is regression of disease post-treatment. And that's something that's very positive to tell patients that once I always tell patients, you're not going to go back to normal, but we can hope that it will get better. Once someone has cirrhosis, the big issue is we worry about liver cancer. And the incidence of liver cancer we have seen really rise in the last decade. And part of the reason for that is the advanced disease of the baby boomers with Hep C. So 1 to 4% of patients with cirrhosis do go on to develop liver cancer. Okay, next slide. So one thing that everyone thinks about with Hep C is that it's a liver disease. What we know is that it's beyond just a liver disease. It's not just the liver that's affected. Certainly the hepatocytes are, but so are the lymphocytes, so are the astrocytes. So it is actually has a fair amount of what we call extrahepatic manifestations. Next slide. So involved in these manifestations are depression, cognitive impairment, chronic fatigue, cardiovascular disease, diabetes, lymphoproliferative disorders, mixed cryoglobulinemia vasculitis, and skin manifestations. So frequently, we will see patients say with diabetes, once we treat their Hep C, their diabetes improves, their renal function improves, their dermatitis, their porphyria, their fatigue, their depression. So a lot of that has not been quantified, but it certainly has been captured as we've progressed in our treatment. So my point with this slide is that it's not just a liver issue. There are other manifestations and reasons to be aggressive about getting people treated. Next slide. So when we put this together and kind of had the idea of what we were going to do, I wanted to make it sort of an update. And just, I think last month, actually it was April, the U.S. Preventative Service Task Force put out a recommendation for universal screening, one-time screening for all individuals aged 18 to 79 years old. So this is new. We certainly had the recommendation about baby boomers, but this is across the board. And so for those of you that are in primary care, since this is a new recommendation, the trickle down of it coming in the insurance coverage has yet to occur, but just be aware that that is across the board. And then if we go, next slide. To the CDC's recommendations. So this slide is looking at recommendations for screening. And I've already alluded to the Preventative Task Force new recommendation. But the CDC is also in the process of updating their recommendations. And we expect that to come forward probably by the end of the summer. That includes all pregnant individuals should be screened, and obviously anybody with risk, HIV, prior blood recipients, individuals with a past history of injected drugs. And I want to pause there because so often if someone is not injecting now, you can't dismiss that. The importance of getting a really good history to know that that could have been a risk factor for them. Individuals born of an HCV infected mother. That's actually pretty low prevalence, but nonetheless, they should be tested also. The third agency that has recommendations is the American College of Obstetricians and Gynecologists, and again, the screening of all pregnant individuals. And then the AASLD and IDSA has a one-time recommendation, again, for all people 18 and up with regard to exposure. Okay, next slide. So this is a kind of a busy slide, but I think it's important because it's new. And new, I guess, is always a relative term. It's new as of November 2019. AASLD basically came up with an algorithm for simplified treatment. And as we look at that goal of having total eradication by 2030, that is not going to happen through our GI practices and our hepatology practices. It's got to happen through primary care. It's got to happen through substance abuse clinics. You know, we've really got to broaden this. And in order for that to happen, the kind of parameters needed to be simplified. So this recommendation is very importantly for individuals without cirrhosis. So the big question as you are screening your patients is, you know, are they cirrhotic? And we'll talk about some of those treatment screening issues here. So in order to assess for cirrhosis, important parameters are to check, first and foremost, platelets. If the platelets are below 150, you have a red flag. You also want to potentially get a fiber scan. Those may or may not be available. Some institutions have what's called elastography, which is not the brand name of fiber scan, but basically accomplishes the same thing by measuring the stiffness. And the fiber scan should be under 12.5 kilopascals as far as the measurement level. Another real easy way to check is something called an APRI, and that's the AST to platelet ratio. It's a very simple calculation that can give you insight. And then the FIB4, if that is greater than 3.25, that would be an indication of cirrhosis. So when I talk to primary care, I really spend a lot of time talking about what is cirrhosis, how do you identify it, because again, this simple algorithm is not for the cirrhotic patient. And also there are therapies that need to be reconsidered if someone is indeed cirrhotic. So the other thing with regard to pre-treatment assessment is to look for drug-drug interactions. There are some specific drugs in the Liverpool hepatitis resource is a really excellent one. Can be easily downloaded on your phone. You want to talk about the treatment therapy, the duration, which would either be 12 to 8 weeks, depending on your agent that you've chosen, and the importance of alcohol avoidance. That actually has also been updated somewhat. In the past, individuals who were using drugs or who were actively engaged in alcohol use, we would basically hold off on treatment for them. And that is not the case anymore. There's been numerous studies that have looked at the success of treatment in individuals actively using drugs and using alcohol, and basically found very good outcomes. You know, in an ideal world, certainly, I always am going to bring that up, but it is no longer an obstacle to treatment. So that again is a change that has come along within the last year or so. So moving to the blue box, patients who have any of the following would not be eligible for the simplified treatment. So if someone has been treated before for Hep C, we talked about cirrhosis. If someone has had liver transplant, if someone has HIV or they have positive Hep B surface antigen, end-stage renal disease, or are pregnant. And so back to the assessment, another parameter would certainly be to assess for pregnancy in women of childbearing age. So what are the regimens? There's basically two that are out there, so that's pretty straightforward. One is commonly known as Mavorite, and that is in the orange box, and that is glucapavir and pibrentsir, and that is 3 pills a day for 8 weeks. That is appropriate unless someone has decompensated cirrhosis. So cirrhosis that is child B or child C. The recommendation for decompensated liver disease and well, we're not going to go to that yet, but I'll get to that in a minute. The other option is Epiclusa, and that's sofosbuvir and velpatasvir. So both of these regimens are combined in a single pill, but with the glucapavir, that regimen has 3 pills a day for 8 weeks, and the Epiclusa has 1 pill a day for 12 weeks. So, okay, next slide. So kind of going, the monitoring for these patients, you know, I think the first visit is always getting your lab and providing information and education. But if patients are on anti-glycemic, there is the potential for symptomatic hypoglycemia, and so you need to monitor for that if patients do have underlying diabetes. Also, if patients are taking warfarin, that you would need to watch the INR and monitor that during treatment. In our practice, once we start patients on treatment, we will actually for the simplified patient, we'll make a phone call. At one point in time, we had them come in at 4 weeks, at 12 weeks, and then to check for a sustained virological response. I think telemedicine has prompted all of us to do things a little differently, and it's good, I think, in some ways. But specifically for the Hep C patients, while they're on treatment, to be able to monitor them through telemedicine is certainly, if they're in the simplified plan, appropriate. After treatment is completed, down in the first bottom box to the left, basically you would wait 12 weeks post end of treatment and check for a sustained virological response, or an SVR. And if patients had other underlying disease, or if you finish treatment and their liver enzymes are still elevated, those patients should have continued monitoring because there's probably something else going on. At the end of treatment, liver enzymes should normalize. After the SVR is achieved, there's no liver-related follow-up for non-cirrhotic patients. But again, those that have underlying risks, IV drug use, men of sex with men, issues of other underlying liver manifestations certainly would be followed up on a regular basis through their GI or hepatology practices. God forbid, these treatments are 98% effective that we are talking about, the new therapies that are out there. So 98% cure rate. If a patient is not cured with these regimens, there is what we call salvage therapy, and that is Bocevi. And so that always is a question patients will ask. Gosh, what if this doesn't work? What are my options? And the good news is, yes, there is an option, but that is highly unlikely because the therapies are so effective. That concludes my portion. I kind of tried to focus more on just updates. Again, because we are in East Tennessee, a lot more of the younger population that we're seeing, and I am actually going to turn this over back.
Okay, thank you so much, Jackie. Thank you all, Dr. Choi, Dr. Saab, and Jackie for presenting today. I think the information was great. We have reached 5 o'clock, but if you do have any questions, please email us at education@liverfoundation.org, and we will be sure to answer your questions. I just want to see if any of our panelists have any last-minute things to say, and then we will bring the webinar to a close.
Get the Hep A and B vaccine.
Thank you. Okay. Yes.
Thank you. Thank you for inviting us, Megan.
Okay, we're going to bring the webinar to a close. Thank you all so much, and I hope that everyone learned something today. Thanks.
Thank you.
Thanks,
Bye-bye.
Jackie. Thank you. Bye-bye.
Bye.